Good morning also from our side, and welcome to the session. Until everybody is safe, no one is safe was a sentence that I actually heard on Wednesday in a side session here at Escaide, and it stayed with me until today because I think it's also a very fitting sentence to start our third topical day here at Escaide. Because in the field of infectious diseases, despite continuous efforts and progress over the last decade, despite frameworks and joint actions, we all know and still see that there are certain communities that still face differences in their health status based on the conditions under which they were born, live, or work. And in these sessions, our three speakers will introduce us to data and evidence on how these persistent disparities that continue to affect populations that are vulnerable for infectious diseases really manifest in practice here in Europe. So more in detail, we will focus on we will dive into three specific areas. The one is prevention and treatment of HIV and bloodborne infections, and then we also have the topic of vaccination and equity, also in regards to ethnic minorities and migrants. But the goal of this session is not only to identify and to name the challenges, but also we will try to discuss some root causes and also hopefully some actionable strategies like monitoring, research and community-driven approaches to help in our field to ensure that really the health services are equitable, inclusive and accessible to all. And with this, I hand over to you, Miłosz, to introduce the speakers.
So welcome to this Friday morning. We have three fantastic speakers today. First, Vivian Bremer from Robert Koch Institute. Vivian is the expert in HIV, hepatitis and STIs and is leading a division related to that. Then Susan Hane from Public Health and Environment Institute, RWIM, which I cannot pronounce, I'm sorry, I was trying to, from Netherlands, who is the expert in vaccinology, and Adrian Stojka from Arges County Directorate of Public Health Romania, who will go into a little bit more detail from the more local and implementation perspective. So also I would like to remind you that questions, as every day, can be asked either in person or via a Escaide app, so you can either use the microphones which are here or submit it and we will moderate it and we will ask it during the discussion time. And moderator will pick up the both in-person and online questions and we will have relevant discussions which I think are key in these very sessions. So back to you.
Yeah, thank you. And I think without further ado, we start with Vivian, who will tell us a bit more about the field of HIV and bloodborne infections.
Yes, thank you very much for the invitation. And I have no conflicts of interest. So let me start talking about HIV combination prevention. So it's a comprehensive approach with biomedical, behavioral and structural interventions, and it comprises, for example, the use of condoms, harm reduction like sterile syringes and needles, HIV test and treatment, policy and education, and also PrEP, the HIV pre-exposure prophylaxis. And I would talk about equity, starting with the example of PrEP, because for all those who do not yet know what PrEP is, it's a preventive HIV medication that can be taken every day to avoid having an HIV infection, and is very effective. So when we look at the number of people using PrEP in Europe, here we have the latest number that will be published in a couple of days, and it was provided by Timo Nori at the ECDC. We can see that there are some countries that have a very high number of PrEP users. So these are the UK, France, Germany and Spain. And then we have a lot of countries that have very few PrEP users, so just a few hundred or maybe just a few dozen. So there are large differences between the countries. And in addition, we have not reached yet the target of 500,000 PrEP users in Europe. Most countries that are reporting PrEP use, they're reporting more than 90% of men are using PrEP, and among those, most of them are men who have sex with men. So if we look at Germany as an example, here we have estimated that we have about 49,000 PrEP users. And of those, again, most of them are male, most of them are men who have sex with men. And approximately 30% of those are living in Berlin. And when we look at the maps, so these are the maps with the estimation and the calculation of PrEP users, or those that get PrEP when they are in need of PrEP. And for example, in 2025, we see that in Berlin and Brandenburg, over 80% of people who are in need of PrEP would also receive PrEP. However, in other regions, like in the north of Germany, they're down to 20% of people who would receive PrEP. So there's a large also urban and rural gradient. So some regions, it's much more difficult to receive PrEP. And what about other people that have a risk for HIV or viral hepatitis? So women, for example, in sex-positive networks or with many partners. We have migrants, legal or illegal. We have people from trans communities, people in sex work, people who inject drugs, homeless people, or prison inmates. And all these populations are not mutually exclusive, but they also can very hugely overlap. And we know that many of these people also face really some barriers. So they face high stigma and discrimination and structural barriers to health, such as a lack of health insurance, for example, or language barriers. So let's look at all these other populations, and we do not have a lot of data on them. So here, for example, we see that only few countries are reporting also disaggregated data for all the other populations. And of all PrEP users, 24% were reported to be migrants. However, there's only 8 countries reporting on it, so the true proportion may be much lower. And then we see people that inject drugs, women, and sex workers and transgender people, a very low percentage of PrEP use. And also here again, we see that not all countries are able to report on it. And if we look at PrEP for undocumented migrants in Europe, so which countries are able to provide PrEP for undocumented migrants? There have been 16 countries that say, yes, we can provide PrEP for undocumented migrants. 14 countries do so. 16 countries said no, they don't, and 11 countries said, well, they have other options. But these other options may be just individual solutions, and in the end, maybe many people can also end up with not having access to PrEP at all. This is, for example, also the case in Germany. So, talking about women, the number of women that have been reported to ECDC receiving PrEP at least once, here we have a lot lower numbers, and apart from the UK and the Ukraine, the numbers are very, very low. And overall, we have 2.5 of all people receiving PrEP that were women. And for example, in Germany, we have reported 400 women receiving PrEP, which is amounting to only 1% of all PrEP users, so very low proportion. And if we look at prevention in people who inject drugs, prison inmates, or people experiencing homelessness, well, they have very, very limited data. Most countries do not report any data. There's very, very few studies on it. And here in Germany, regarding people that are injecting drug, we have very recent unpublished data that people who currently inject drugs, 20% have heard of PrEP and 3% have ever used PrEP. Now, you could, of course, argue, well, PrEP, maybe it's not a prime prevention measure that you need when you're injecting drug. You need probably sterile syringes and needles, because this is also preventing hepatitis. And you can have a very good treatment, for example, for hepatitis C. So what about this? What's the situation? Well, the number of sterile syringes distributed per person who inject drugs per year is in the report from the EUDA. And we see that there are a number of countries that are providing more than 200 sterile syringes per year to drug users. So, for example, these are Austria, Greece, Luxembourg, but there are way more countries that are well below this threshold, also including Germany. And needle and syringes programs in prisons, here we have only Spain and Luxembourg that are providing sterile syringes and needles in prisons. You see Germany is also here in green. However, in Germany it's only one prison with female inmates that is providing sterile syringes and needles, and no other prisons, so it's actually not counting in. Now, why is this so important to have these programs? Well, if we look at hepatitis C prevalence in people who inject drugs and also people experiencing homelessness, here the example from Germany, we have here data from 3 different studies that have been conducted in people who inject drugs, and we see that the prevalence of hepatitis C is very high, as well as also the active infection. And it has also not decreased over time. And this is something that really indicates that these people have huge barriers to either prevention and also treatment. When we look at people experiencing homelessness, so these are examples from 2 studies, it's also that they have a high prevalence of hepatitis C, 12 and 16% respectively, of active infections, so much, much higher than the general population. And in all those, there's a high proportion of people that report prison experience, and also a higher proportion of hepatitis C among former prison inmates. And if we try to construct a cascade of care like we do usually for HIV, if we do this for hepatitis C in people who inject drugs and also in people experiencing homelessness, then we see that of those who have ever been infected by hepatitis C, many of those are never diagnosed, and many of those have never been treated. So we see that there's still a lot of room for improvement. So basically what we see here is a kind of syndemic. We see different factors that are interacting in synergy and that are amplifying the infections of HIV, hepatitis B, hepatitis C, and TB as well. And these are homelessness, migration, sex work, drug use, and prison. So, for example, people that are using drugs, they often end up in prison. When they're released, they're getting homeless often, and a lot of migrants are there. Sometimes then they have to do sex work just to finance, for example, their drug use, or just to have money at all. And all these factors are amplifying the risk of infection, together with also other factors like crowding, like poverty, language barriers, stigma, and lack of health insurance. So, as a conclusion, the access to HIV PrEP is depending on the country and region of residence, your migrant status, and insurance status, gender, rather than the real risk of infection. And the access to harm reduction, like sterile syringes and needles, but also to treatment, is largely insufficient, especially in prison settings. And we have a syndemic of hepatitis C, HIV, TB, migration, injecting drug use, homelessness, and sex work, which is actually warranting an integrated approach in prevention, in testing, and also in treatment. So I would like to thank my colleagues that have also contributed to all these data at the Robert Koch Institute, and the colleagues from ECDC and EUDA, and especially Timo Nori, and thank you for your attention.
Yeah, thank you very much, Vivian, for those very clear examples and data from Europe and Germany as well. And we will jump right into the questions from the audience, here and also online. And I would ask Martin if there is any questions from the audience. I see some, but...
Good morning, and thank you very much for your presentation. So, ladies and gentlemen, online and in the audience, this is your moment to start writing in some of those questions. We have a couple here. We also have a gentleman there, but let me just, if you would bear with me a minute, sir, let me just go straight in for a clarification. First question, is PrEP only for HIV or also for hepatitis? I think you just answered that in your last slide, but could you just specify again?
So HIV PrEP is only for HIV. Yes.
Right. Thank you very much. But these things are overlapping.
Yes.
Yeah. Okay, great. Sir.
Hello, Aaron Noel from France. Thank you, Vivian, for this great presentation. It was very interesting to see that. I was wondering whether the success of PrEP among MSMs is maybe not reproducible in other communities because they're highly inserted into the society. Should we rethink about the way we distribute PrEP and maybe finding better ways and a better way to administer PrEP? What about long-acting PrEP?
So, certainly you have a point that it is more difficult to have PrEP also in other populations. Like MSM, they wanted PrEP. So there were communities that were advocating for PrEP and fighting for PrEP. This is certainly not the case in other populations because they have a huge amount of other problems. But it shouldn't stop us from also promoting PrEP in these populations because they have also a benefit from it, a very clear benefit. And it has also, some countries are more successful than others. So in the UK, for example, you have more women taking PrEP. Also in the Ukraine, you have other countries where migrants have access to PrEP. Of course, you need to tailor really then the program so that people understand first what is PrEP for, what are the benefits, how can I really protect myself, because in many of these subpopulations, PrEP is simply not known yet. So we need to start really from scratch here, and eventually I think that many people, or many more people, can benefit from PrEP than they're doing now.
Thank you very much. Now, we don't have very much time, but I'm just going to combine two questions together that seem to be linked. They've just moved. Here we go, got them back. What's the recommendation for PrEP use in Germany? Is it gender specific? And I'm going to combine that with the question, what are the possible strategies to identify women at risk and who are eligible for PrEP? Is the availability of long-acting PrEP regimes providing new opportunities for HIV prevention in women?
Okay, these are 3 questions.
But only 1 minute to answer.
I forgot the first one already.
What are the recommendations for PrEP use in Germany? Is it gender specific?
No, it isn't. So everybody who has a high risk for PrEP can, in theory, access PrEP. So it's not restricted just to men.
Okay. And then Is the availability of long-acting PrEP regimes providing new opportunities for HIV prevention in women?
Well, absolutely. I mean, lenacapavir, the long-acting PrEP, is a game changer, a potential game changer, I would say, because it also depends a little bit, but it will really make people, it will remove a lot of stigma, because people just have to turn up for the injection and then they don't have to think about it anymore. So in a way, they don't have a pill that is at home and people are asking questions, oh, what are you taking? Ah, you have HIV. So all these things will be removed, and it's very, very safe. You don't have to think about, oh shit, I forgot my PrEP tablet. And therefore, it has a lot of potential.
Okay, thank you very much. I would encourage you after this session to please have a look at these questions and answer them directly as well. But back to our co-chairs.
Thank you. So now let me welcome Susanne Hane to the podium. She will be speaking on vaccine-preventable diseases and how to tailor immunization programs, especially from the perspective of people who really need it, so with a lower uptake. Susanne, the floor is yours.
Yeah. Thank you, Miloš, for that introduction, and thanks for the opportunity to allow me to exchange some ideas with you here at the SCADE, and on a topic that is close to my heart, vaccine equity. So I do not have any conflicts of interest, but regarding commercial interests, I want to state I have co-authored a book on vaccination programs, which is now available free of charge, and I'm editor-in-chief of Epidemiology and Infection. So in this talk, I want to go talking about vaccine equity, but I want to focus on what we can do as epidemiologists. That's the focus of the talk. I'll start very broad with public health, health inequality, vaccine equity, and focusing on applied epidemiology, examples from the Netherlands, and also ethical aspects, and then a synthesis and wrap up. Now, as we all know, in public health, our aims are to increase health of the public and to decrease health inequalities. However, at meetings, I've often come across that people say, oh, but the second statement is political. You should be more objective in public health. We are here for the health of the public. You mustn't get political. I really do not agree with that at all. It made me really outrageous at these meetings. It's a primary principle of public health to improve health of the public, but also to reduce health inequalities. And I think in many countries in Europe, it should be the primary aim because our levels of public health are actually quite high. So it's not a political statement to reduce health inequality. Now, the reasons that we need health equity, health equality, is that more equal countries, whether they are rich or poor, have better outcomes on many health indicators, and you can read about it in this book. And the book also has this image, or this graph, where you see a selection of high-income countries, and they're plotted against an x-axis of income inequality and a y-axis of health and social problems. And you can clearly see the linear relation where the US is in the very much unfavorable corner with a lot of inequality and a lot of problems. And Japan and the Scandinavian countries are in the more favorable corner left. Now, what can we do as epidemiologists to increase equality, to make our public health programs, like the PrEP program, more equitable? And since vaccination is, after safe water, the most effective intervention for saving lives and promoting good health, equitable access to vaccination is a public health priority. And in this image, you can see what we mean by equity. So people who need it most get most of the services. But the reality also in the Netherlands is that people who need it most often benefit or access the services least. And I have an example from COVID vaccination in the Netherlands. So here you see the COVID coverage, autumn round 2023, people aged 60, by country of origin and stratified by welfare. So here we have the stratum of the low welfare, and you can see the pattern that Dutch people with a migration background have much lower coverage, except those from Indonesia, and especially those from Morocco and Turkey. And by showing the other stratums, you can see that this pattern is replicated across the strata. So it's really independent from the welfare status, and it's a persistent pattern. Now, if you then look at COVID hospitalizations, and we looked at people who are unvaccinated, so you see an effect that is independent of vaccination. You see that the same groups, especially migrants from Turkey and Morocco, have the highest risk of hospitalizations. And the reasons for this are not really well understood, but the whole situation makes clear that the people who need it most access the preventive service, vaccination, least. So that's a clear example of inequity. Now, WHO defines it as avoidable differences in immunization coverage. And in their definition, they also highlight why it's important. So, firstly, inequity is unfair, so it's undesirable and leaves people at high risk of preventable infection. But if you have groups with inequitable access, there's even more risks of outbreaks and spillover. And as was stated in COVID times, this was summarized in no one is safe until everybody is safe. And we need this equity to make our society stronger and more stable. And unfortunately, we live in a time where this is needed most because we have a lot of headwinds. First, there's the headwind from the east. We are all very much aware of, also being in Poland, and it requires us to spend a lot of budget on defense. Specifically on vaccination from the east, we've seen undermining efforts to undermine trust with these Russian trolls. And I think we should, as epidemiologists, really study this. What's happening there? What are the effects of it? And then there's even headwinds from the west more recently. And Andrew Pollard summarized that in The Lancet. And he talks about his despair, the despair that he feels, that we are really, because of the enormous cuts in funding, in a situation where there's big backsets to progress that we've made in the past. And in addition to this big gaps in funding, there's now also this more politicization of vaccination. It was always there, but to the extent we are seeing it at the moment from the US, it really is amazing and very sad to see, especially if we saw the comment by CDC yesterday. So the question is, are we Kennedy ready in Europe? Are we prepared for all of this? Lots of things blow over from the US. Will it happen to us? And then the question is, what can we do? So I want to share a little personal story. So a couple of years ago, I moved house, and then I met a neighbor. And the neighbor said, "Oh, I'm a GP, what do you do?" And I said, "Oh, I'm an epidemiologist." And he said, "Oh, you're a person who counts." He says, "You're a person who tallies." And then afterwards I thought, no, I'm an applied epidemiologist. I work in infectious diseases. And then I thought, does that give the value to what I do? Because it's applied to measles and mumps, counting these cases. And then I thought, no, it's actually working in a public health framework where we work together with other disciplines to affect change and to make a difference to the situation. And I think that is what is changing and what gives the added value to the profession. So in the context of vaccine equity, that framework is the tailoring immunization programs, and we can add value in lots of the stages, nearly all of the stages, but I think especially in research. And an example from the Netherlands is from my colleague Joyce, who looked at determinants of vaccination by linking national registers. And what she found is that overall the coverage is decreasing, but there are many faster declines in coverage, especially in Dutch children of Moroccan and Turkish origin. And there were really pronounced declines there, and it's published in Eurosurveillance. And you can see in this graph that the children with Dutch origin from Morocco initially were higher than Dutch children, but suddenly there was a decrease, and that decrease accelerated. So we do not know what is behind it, but when we first saw this at RIVM, there was no immediate consensus as to whether we should even publish this, because people said, yeah, it's potentially stigmatizing, and are we doing an adverse effect? And then we had further discussions and, of course, went back to ethical principles. And in medicine, there's the first principle of do good and do no harm. And I think it should also be the first principle in public health, that we do not do any harm. There's even a professor in the Netherlands who states that in health promotion, by stigmatizing communities, we actually do have a role in the persistence of health inequalities, and that we should turn more our eye to the real determinants, which is social media and the politicization of vaccination. So at RIVM we had discussions about this. Should we go out with these findings? And Tjalling Leenstra, a colleague at RIVM, was very instrumental. We did a very systematic approach to this, which is called a moral deliberation method, where you look at areas of uncertainty and make sure the rights and interests of all stakeholders are fairly weighed. So the outcomes were that we did publish the data, but that we spent extra attention to the text and that we spent more efforts on dedicated communication. And I think for our epidemiological practice, there's always ways to improve the way you express things and the way you write your text. For example, use socioeconomic position rather than status, because status is very fixed. Apply this method of moral deliberation, and maybe we should also think of having better proxies for risk rather than country of origin. We look at networks and we look at perhaps synthetic populations to study infection risks. There's no time to go into this video. I think what I heard from Dutch Moroccan people is that it was very well received. It's about cervical screening. And I think the strength of it is that it starts from a real-life perspective, a real-life context, the hairdresser's saloon, and not from a public health framework where normal people do not want to be stuck in. So, to wrap up, vaccine equity is really urgent. And we do need to make our society stronger, given the headwinds that are coming to us in Europe from the East and from the West. The politicization is a real threat. We need to discuss and see how we deal with that. And the question is, are we Kennedy ready in Europe? I've talked about some innovations, methodological, so moral deliberation methods, improving proxies, building synthetic populations. And as field epidemiologists, I think we need to keep up the good work, stay strong, do what you do, look for inequity, do not turn your eye away from it, but communicate the findings in an ethical way. Focus on your actionable outcomes in a programmatic approach. And we need to really expand our skill set into things that help in the current situation. So infodemiology, ethics, synthetic populations, network analysis, and also extend our collaborations with people who have expertise in all of these areas. And I think the conference is a great platform to do that, to learn about new things. So thank you for your attention. Thanks a lot to RIVM colleagues, and pointing to our book that is free available online. Thank you.
So, thank you, Suzanne. Fantastic presentation. And while we welcome Martin again on stage with the questions, can I start with one? Actually, what you have just said, Kennedy ready and misinformation in vaccinology. So what would be the practical tips how to tackle misinformation and vaccine hesitancy in real life, especially in the special groups like migrants, like people with other beliefs, people who are culturally also slightly different?
Yeah, so mis and disinformation, I think personally, and also as epidemiologists, maybe we need to better study it. I think that would be my first response, that this whole field of infodemiology, for me, it's still new. We need to study what are the messages, what is the effect, which group are taking which messages. And I think there's a poster from Amsterdam doing exactly that, studying it. So that would be my first response. And then if we better understand what's happening and what are the effects, we can better think of interventions. And the interventions are also innovative, like pre-bunking and debunking and even immunization against misinformation. And yeah, so it's a whole new field. And to me, it's a question, should people become infodemiologists? Or should epidemiologists be more trained to also work into infodemiology? But that's a question with all of these areas. So how far is it a specialization? And but in any case, we need more general people to oversee the whole situation.
Thank you. So info epidemiology, I will remember this, and to Martin.
Please, we have a question from the floor. If you could just introduce yourself.
Yes, thank you very much. My name is Stine Nielsen. I work at the National Institute of Public Health in Denmark, SSI. Susan, thank you for a perfect presentation. It was really inspiring, and I think it linked very well with the discussions that we had yesterday at the bar camp about how do we as epidemiologists or microbiologists engage more with community. And you mentioned it also now, do we need to is it our role? Do we need more people at our national public health institutes that do this type of work? Have you any experience from the Netherlands or Germany or Romania? It would be very interesting. Thank you.
Yeah, so thanks, Tina. And I think, yeah, we do need more people, but more people at all levels. I think it's a whole area where we have to do more studies. I mean, the Russian troll thing, it raised a lot of attention, maybe pre-COVID. But I think it's probably still happening, but it's not being studied. So, yeah, we need to strengthen public health to be more active and to deal with these things.
Very quick question. I'm going to combine 2 or 3 different comments from online. This is all about evaluating the access and the equitability to vaccine programs. So have you explored systematic approaches for evaluating vaccination programs to ensure they are delivered equitably, is one question. And that's reinforced by another question which says, for example, if parents are divorced, you need 2 signatures. In the case of parental opinions on vaccinations, does that become a barrier then towards getting vaccinations? So what's your approach to the equity, availability of the vaccines?
Yeah, so the programs are there free of charge, and we evaluate the equity by doing research. We are in a fortunate situation that we have a national register, and all Dutch children are in there, even the unvaccinated ones. So because it's population-based, so we can really study that by linking it to national statistical data in a secure environment. And then, the parents are the ones choosing for the child. So if they are hesitant, the child is the victim. They are responsible. And so from a child perspective, it's really inequitable to have parents who refuse vaccination. So I think the hesitancy thing, especially for infant vaccination, is difficult because some people are hesitant, the parent, but the children are the victims. So I think we should look more from the children's perspective and do everything we can to understand what are the underlying reasons and do everything we can to improve it.
Thank you very much. There are a lot of more questions, so right. After the plenary, please do go through the app and answer as many as you can. Yeah. Thank you very much. Back to our co-chairs.
Yes, thank you. Thank you, Susan. And we stay with vaccine inequity, and next up we have Adrian, who will dive a bit more into vaccine inequity seen in the Roma population in his region. So, the floor is yours.
Thank you, Nadine and ECDC for the invitation, and good morning, everyone. In my presentation, I shall focus on vaccination inequities in a Romanian county. Immunization is one of the most effective public health interventions, and in 2021, member states of the European WHO region agreed on 7 strategic priorities for their vaccination programs, by unanimously endorsing the European Immunization Agenda 2030. High and equitable coverage with essential vaccines is one of these. Making vaccines available and accessible to people of all ages, integrated with other essential health services at the primary healthcare level, is also being prioritized. But why is immunization equity so important? Measles, a sensitive tracer of immunization underperformance, makes it clear. With over 25,000 measles cases unevenly distributed across Romania, the 2024 measles outbreak showed inequalities that suggested existing immunization inequities. To gain more aware of these immunization gaps, starting 2022, Romanian public health authorities decided and prioritized restoring the routine immunization in Romania. As a consequence, COVID-19 vaccination was integrated with the routine vaccinations in the National Vaccination Program, and the old electronic immunization registry was integrated with that of COVID-19 vaccination into a more advanced digital platform. The regulatory framework of the National Immunization Program was updated, and so was the National Plan for eliminating measles and rubella by 2030 in Romania. The National Vaccination Strategy adopted in 2023 envisioned an equitable access to essential vaccines for everyone at any age, everywhere. And a national measles outbreak response plan was approved in 2023, and that included catch-up measles vaccination accelerated. To gain more insight into vaccination equity determinants, in 2024, the National Institute of Public Health conducted a qualitative study to understand vaccination barriers and drivers. Healthcare staff and caregivers from two low-performing in rural low socioeconomic status and one well-performer county, and also in rural low-performing economic and low socioeconomic status counties were included in the study. Health staff in the two low-performing counties frequently reported challenges working with Roma population due to their mistrust in the health system, while Roma groups in the well-performing county reported frequently trust in health staff. So the study results show the importance of repeated reminders to mobilize caregivers for vaccination sessions and communicating better with them by tailoring messages to their concerns and literacy level, and explaining how vaccines work to alleviate unfounded fears, as well as a fair treatment irrespective of their ethnic or ethnicity or socioeconomic status. Argeș County, situated in the middle of the country, has a total population of about 600,000 inhabitants, living in 102 administrative divisions, of which 7 are cities and 95 communes. Communes are rural settlements. The 17,000 registered Roma ethnics accounted for nearly 3% of all the county population, and there are large Roma groups of over 6% of the total population in 22 communes. Also, Roma settlements are in 14 communes as shown on the map, and here they account for over 12% of the commune population. In our experience, Roma population is highly mobile, frequently traveling in and out the county in Romania and abroad. Most of them seek health care only when sick, and that includes their children, making vaccinations more difficult. Also, there's always a fluctuating number of unregistered members in the community, which makes tailoring health services more difficult. Measles epidemiology in Argesh County showed inequalities in 2024 and also pointed to inequities in the county. The coverage with the first dose of measles-containing vaccine, MMR1, was 73% for children under 7-year-old, but only 67% for those under 5. Of the 1,131 measles cases confirmed, nearly half of them were under 5. County incidence rate was 186 cases per 100,000 population, and measles incidence rates correlated negatively with MMR1 coverage in under 5-year-olds, suggesting inequalities across the county. Furthermore, coverage with MMR1 in under 5-year-olds was below 67% in nearly 2/3 of the county localities, shown in red on the left side map. Measles incidence rate was above 200 cases per 100,000 population in 1/3 of the county localities, which is also shown in red on the right-hand map displayed. 86% of communes with large Roma settlements had MMR1 coverage in under 5-year-olds below 70%. And communes with Roma settlements had 3 times the measles risk of those without. So outbreak data suggest we should reach Roma population better with routine vaccinations. Information on reasons for missed measles vaccination during 2020-2024 was reported for only 3% of all missed. However, refusal is the most frequently reported reason at 76%, followed by contraindications. So what has been done to improve vaccine acceptance in the county? County Directorate of Public Health leads a team work to support vaccinations. The program managers meet monthly with family medicine doctors to share information, discuss challenges, and identify together solutions for improving vaccine acceptance. The community health coordinator convenes monthly meeting with Roma health mediators and the nurses who liaise with the health system in the community. The Office of Health Promotion has conducted monthly vaccination promotion activities on traditional and social media or on our own website, in the community and in schools starting 2023. 2 outreach measles vaccinations we conducted in Roma settlements before 2015 caught up nearly 50% of those unvaccinated. However, they were quite highly resource demanding. Local administrations also applied to establish integrated community teams and centers. An integrated community team is made of one community health mediator or nurse, 1 social and 1 educational assistant. 38 communes applied, and so far 31 have already established their teams. There are 8 Roma health mediators and 13 community nurses in the county. Integrated community centers deliver services, healthcare, primary healthcare and social services close to Roma and other underserved communities and populations. So far, 6 communes applied for establishing centers. 2 have already established and 4 are underway. Concluding, the vaccination program is adequately resourced. However, it underperforms in Argeș County. How could we do better? It's clear we need to understand better caregivers' reasons for missing vaccination and communicate better with them. Possible next steps for the Directorate of Public Health are to continue working with family medicine doctors to improve reporting on reasons for missed vaccinations and improve communication of medical doctors about vaccination, particularly using motivational interviews with those hesitant caregivers. Work closer with community health services to improve communication with Roma population groups. Gather vaccination behavioral insights from underserved population, prepare tailored communication messages to promote vaccinations, and consider organizing catch-up vaccination campaigns coupled with health promotion, with vaccine promotion. Also identify innovative ways to reach hesitant caregivers with relevant messages, monitor closely the vaccination program performance, and use data triangulation to expose inequities and further explore them. Strengthen traditional partnership also should be continuing, and identifying partnerships outside the health system could be of help, especially when we reach out in these vulnerable communities. And with this, I conclude by thanking you for your attention.
You can come back. Thank you, Adrian. Excellent presentation and very valuable insights, I think, in your county and in this particular example. I think we try to have the questions from online in the audience now, before we go into our discussion up here in the plenary. And I think there is one. Should I read it out? Or?
Martin.
So there is one question online, which is: anthropology approaches were always needed to understand different behaviors leading to success or failure. For example, approaching Roma population in Eastern Europe countries or population in Ebola in West Africa. Could you comment on that?
Well, yes, thank you for the presentation. Behavior change is a challenging endeavor, and as I have already presented, we have initiated such endeavors to better understand the behavior of underserved population regarding vaccinations, the barriers and drivers, and what are the reasons behind this behavior. This is in the very beginning in Romania, and I think we need to take and replicate these studies in more counties in Romania to understand better the diversity of situations that each county has. Behavior change takes time, and understanding behaviors should be initiated as soon as possible to be able to tailor interventions aimed at better access and ultimately embedding immunization equity into our national vaccination program.
Yes, thank you. We have also one question here in the room, so would you mind asking it?
Thank you. I'm Raquel from Bulgaria, and I'm the EPIET Fellow. I wanted to really understand two questions. You mentioned that in Argeș County there were 17,000 roughly Roma who were registered, but the actual Roma population was about 12%, more or less, fluctuating. What do you mean by registered? Because I don't think it was explained in the talk. And then what other reasons could be for the different the low-performing county and the high-performing county, why do you think the high-performing county, the Roma population, were more engaged? What systemic issues could be driving them actually, or the facilitators that are working in the high-performing county? Thank you.
Thank you for your question. If I understand your question correctly, it is about the difference in the percentage of Roma population. First, the 17,000 are registered Roma population according to official statistics in the entire county. However, the distribution of this Roma population is uneven, as it was shown on the map. There are localities, basically rural settings, where they tend to congregate to up to 6% of the commune population, and even more by congregating into Roma settlements within the commune, and in those communes they go up to 12% of the commune population. Does this answer your question? No?
Doesn't. I wanted to understand, what does it mean to be registered?
Oh, registered
what does that mean?
Well, registered means that they are known to local administration and to the county statistics. But, as I said, Roma population is highly mobile. Many come in and go out, some of them unregistered. We cannot account for those. There's always a gray area and unknown area, and that's why I said it is difficult to tailor health services and other essential services for these people who frequently come in, go out, and they are not registered with local administration, with family medicine doctors, or other service providers. And thank you for your question. That was a very good one.
And the second one.
And the second one, please. Please.
Perhaps we can take that during the break. Just very concerned about the time. Thank you so much.
Thank you. I think it's important clarification that you could have during the break with Andrea.
Sure, and please do.
And we still have some questions and discussions between the chairs and Slido questions later. But I would like to pick your brains. We have fantastic implementation epidemiologists on stage. So we know that there is certain increase in preventable, sometimes not, but various infections transmitted across poorer, vulnerable groups. So one example may be TB, but we also have HIV, hepatitis, co-infections, STIs. So could you elaborate on what can be done to reach these populations and to prevent further increases and to ensure also timely diagnosis very often in these cases? So Viviane, you first. Yeah.
Well, I think first of all we need really to understand who are the population that are most affected and why are they most affected. So why, for example, they're getting diagnosed late? Why do they not get treatment? What are the barriers to healthcare? What are the barriers to prevention and testing? Are there enough offers also? Are these offers tailored to the population? If this is, we have identified that maybe there are specific groups that are really underserved, completely underserved, like let's now say as an example, homeless people, then we need to see what can we need to take also look at the whole situation, because we need to really have a look at this community, at their living conditions. What are also the obstacles why they cannot attend? Maybe it's just the money for the bus fare that is missing. Very simple things, and this is only something that we can really understand by talking to members of the community, by doing qualitative research, for example. And sometimes it's easy measures that can help really to get them also engaged with care. But it means we need to go out, we need to do, like Adrian has also shown very nicely, to do outreach activities and be active with the communities involved. Otherwise we will never understand what's going on.
That's good. Okay, thank you. And Suzanne?
Yeah, so I completely agree. I think I do not have a lot of experience with this specific part, but I think integrated services from the perspective of people in the community, and maybe not even the public health framework or having a clearly recognizable public health action, but more into communities and where they get together, and then try and integrate it in things that they see as a priority, and at least have integrated services for early diagnostics, screening and treatment, so together with other services where people can benefit from.
Yeah, thank you. And Adrian, you are implementation specialist here.
Right. I think that my co-speakers have actually summarized very well what has and could be done to address this. And I also think that integration of essential health services, mainly at the primary healthcare level, might be the answer to more equitable access to services and screening programs that detect early conditions that are health and life-threatening, together with immunizations as a package of services at the primary healthcare level might be the answer to a more equitable offer of services and better health in the community, especially underserved.
Yeah. Do you have anything to add?
Yeah, I actually think we discussed now a lot about like a quite particular vulnerable group, the people experiencing poverty, but just to zoom out a bit and get a bit more general to many different communities that might be vulnerable to the infectious diseases in your range of expertise. If you could give, like, US applied epidemiologists one piece of advice to our audience, how can they understand better the issues generally faced by this variety of populations, what would it be? And I think we can start with you again, Vivian.
Well, practical examples, I mean, I think it's important to, I'm a little bit maybe repeating myself, but also to engage with the people and also already in research, so to do participative research, meaning that you invite members of this particular community you want to study to also already in the planning of a study, in the creation of the questionnaire, and also in the interpretation of data. And this helps enormously to really tackle the real issues, because you're asking the right questions and you get also the right answers. So that's one first step. And we've done this in Germany, for example, in the study with members of sub-Saharan community. So we wanted to do a survey on sexual health, and when we did the planning in a very traditional way, well, there were members of the community saying, well, this won't work, you won't have a single participant, so please let us participate. And well, it was a long participatory process, but in the end we had many more participants, and we got a lot of valuable information that really helped us also to tailor our recommendations. Same for transgender. We really didn't have access to the transgender community, but through participatory research we could actually get a very good access, and the transgender communities were endorsing our research, and this really helped also again to get very valuable information on these communities that we can use then for really interventions.
Thank you, Vivian, and for elaborating more. I think it's very interesting. I like a lot of the approaches to interpret kind of the data together. I found that very nice, actually. Suzanne, do you have anything to add?
Yeah, so I again completely agree with Vivian. So we are from the same cohort in EPIET, so maybe that helps. But in addition, I think, to summarize what you said, it's this statement of if it's about us, it shouldn't be without us. So that's the thing summarizing work with communities, and I completely agree with that. I think if you are in a lucky situation that you have registers, in the Netherlands we do have that, then you can start with desk research, doing linked register research, and really look at the inequities. It's interesting that in the approach to this differs in Europe. So I heard this morning that in Belgium, actually it's by law not allowed to study different countries of origin in your data. And I think, yeah, that's different approaches in different countries. I think it is epidemiology to at least study it, and then deal with what you find in an ethical way. So I think that's where it starts, but to really understand what's going on in the community, you completely need the participatory approach.
Thank you. Adrian, anything to add?
Well, just to briefly say that in my everyday work at the subnational level, we have to apply science and translate health policies into everyday public health action. And for that we need to take a multidisciplinary approach, which is why we collaborate, as I said in my presentation, the vaccine program manager with the community health coordinator and the health promotion people, because it ultimately takes a teamwork to see a difference out there in the population.
I would like to emphasize one point, and I think this is in relation to the question that was asked on long-acting injectables. So we also are on the verge of implementation of novel innovations in prevention. And as you probably seen with Purpose 1 study, there is 100% efficacy of long-acting injectable lenacapavir in women in high-risk populations in Africa. And also this implementation to the poorer populations and difficult-to-reach populations is something that we should be working on together, maybe even with industry, to really bring these innovations to people in need, to migrants, to Roma populations, to people who are underserved across various populations. So this is also my comment to that, and I think we are in a special place when these innovations exist, and we even in Europe have to think how to get to the populations at risk who might benefit most. Okay, so we still have a few minutes, so we now have some time for questions and further discussions from you, from participants. Please use the online app or the mic if there are still questions, so we will try to tackle both. So before we go on, there is one thing which is pending from the questions that I would like to ask to the panel, which I think is an important issue. So, could religious factors be at the root of low vaccination rates at various populations? And here is the example of Turkish or Moroccan communities in Netherlands, but I wanted to go beyond that. So, to rephrase it a little bit, how could religious factors and cultural barriers be related to vaccine uptake, but also to pre-exposure prophylaxis uptake? So this is both to Suzanne and Vivian.
Yeah, so in the Netherlands we know very well the religious objections to vaccination in our Bible Belt. So that's Orthodox Christian communities, where they really refer to the Bible, that you shouldn't interfere with divine providence. So that means that you shouldn't interfere, be smarter than God to prevent disease. Now in Islamic communities, I think we just still do not know exactly what is the real argument, whether it is to do with religion or whether it's a network, it's a peer influence, it's something else. And I think in the past we've seen examples where vaccines were not considered halal. There was then from Indonesia a big statement that the polio vaccines were halal and they could be used. But it's always a very difficult mix of politics, geopolitics and misinformation. And it also varies much between communities. So I think in the UK there was this issue of the pork gelatin in some MMR vaccines. And, but not all MMR vaccines have this pork gelatin. So I think the way to find out what is really happening is to speak with people and take time and go to the communities. And one thing that helps is to look for organizations that are not public health, but who are from that community. So in the Netherlands, for the Orthodox Reformed, there's this NGO called the Dutch Patient Society, which sounds very unspecific. I mean, patient society, what does it mean? But if you scratch underneath, it seems to be a group of quite Orthodox Christians who also are concerned about health and who are willing to discuss with you. So I think you need to look for organizational structures in the communities. Rather, it makes it easier because otherwise you have to go to all the individuals. And then the question is, in the Moroccan and Turkish communities, are there these structures? Are there NGOs working with them and being part of that community? And yeah, I think we just need to do the legwork. We need to go out, speak with people, yeah, see their perspective.
Viviane, anything to add?
Yeah, well, I think this is a very valid point with organizations, NGOs that are engaged with the community, but also opinion leaders. So we have also very good experiences with imams, for example, or priests. So in religious communities also to go into church, to go into mosques, and to talk about those people that are important in the community who play a pivotal role. And so if you get these people on your side when they see, okay, this is for the interest of people, it's for the health of people, then you can actually move a lot of things. So I think we should try to engage also with religious leaders.
So, very last question. I do not see questions on the mic, so the last one will be for you, Adrian. It's interesting and difficult and on the verge of political issues. So, given the right-wing surge we are seeing across Europe, how can we make sure that data related to minorities will not be misused in the future? So this is basically the question about stigmatization following data collection. So, quick thoughts about that.
Right, thank you for the question. And that indeed is a sensitive question, and the answer to the question could be even more sensitive. So I'll have to be cautious with this. But that may indeed be a matter of concern when we're dealing with the data about specifics of certain population, like ethnicity, religious beliefs, or other sensitive matters. I think there's always a risk of misusing data. I think we need to be carefully looking at the data, using data triangulation to combine data we collect from monitoring programs like immunization program, disease surveillance program, community services program, and try to come up with the understanding of what differences are out there in the community, who is at higher risk, who is at lower risk, but also go beyond those differences and understand reasons for those happening. And then, after looking at the data, we need to be careful when we communicate our finding, because of course in our professional community it may be easier to communicate, but when we go out public with communicating our findings or our results in our everyday work or professional work, we need to be careful about avoiding stigmatization. So communication, I think, here is the key to avoiding the pitfalls of stigmatization when communicating about health disparities.
So one last question with microphone one.
Yes, thank you. Margrethe Grevisdal from Norway. I just wanted to share an experience from Norway and also related to Susan's talk. We have a huge Somali immigrant population in Norway, and a few years ago we saw that the MMR vaccination rates were lower among children under the age of 2 in this population. And so we did a study to see if it had something to do with access to health care, if it was the newly arrived immigrant children that didn't receive the vaccine. But what we actually found was the opposite, that the longer the mothers had lived in Norway, the lower the vaccination rate was. So it turns out that it's actually something spreading within the Somali community in Norway, and not necessarily that they don't access healthcare. And I was also thinking about the Moroccan and Turkish data that you showed, that we don't see the same for the other like Islamic countries in Norway. It's very restricted to the Somali population. So I wondered if you had any insight into the data from the Turkish and Moroccan community.
Yeah, thank you for sharing that. I wasn't aware of that in Norway, and we see the same thing. With the generations, it gets worse rather than better. So I agree with your interpretation that it's something that is spreading within the country. So it seems to be a network thing rather than linked to the status of being from a migrant origin. And we just need to better understand it. Where is this happening? So we have a current study looking at school level uptake, and it shows that Islamic schools have a decreasing uptake. We also have seen outbreaks in those schools. So, but what is it exactly? Is it the religious denomination of the school? Is it the network? We just do not understand it yet. And I think, that's always tricky in public health when you have a finding and you do not understand the underlying reasons. Should you already communicate it, or should you, well, there were voices at RVM saying, no, we don't want to communicate it. We want to further study it before we completely understand it. And I'm a sort of an impatient person. And I think if we have the knowledge, we have to be transparent and we have to bring it out there, because we do not have all the wisdom and knowledge in our center. We need to work together and share our knowledge, and then look at the underlying reasons. So the short answer is we don't know what is the factor.
Okay, so thank you. We do not have time for more questions, and also because the discussion was quite lively, we do not have time for our Slido questions as well. So I think we are approaching the end of the session, and I pass to Nadine to close.
Yeah, thank you so much. Actually, I think we heard a lot about barriers. I think we also touched on underlying issues, on issues related to infodemics, to counteract misinformation, to approach communities directly, to include them in our data collection, in our research, in our data analysis, and also in the communication. And I think we've gotten a lot of food for thought, and also hopefully a bit of a portfolio also on practical approaches that we can apply in our field in epidemiology, in applied epidemiology on the ground. And yeah, with this I thank you for your participation in this panel, and thank you all. If you have nothing more to add.
No, I do. So just a concluding thoughts. So I do think we need to think during the coffee break, are we Kennedy ready for the future? And really to think, how do we tackle misinformation? How do we implement innovations? And how do we actually improve literacy across various populations? I mean health and vaccine literacy. So with this, I would like to thank all the speakers and my wonderful co-chair, and thank the audience for participation. Thank you.
To you.